Hi, I'm Dr. Donna Kimmaliardjuk. I'm one of the cardiac surgeons here at Cleveland Clinic, and my area of expertise and my passion is coronary artery bypass grafting. I'm here today to talk to you about specifically robotic-assisted coronary artery bypass grafting. What is robotic CABG? We'll talk through that, why it's done, how it's done, and really who are the patients that are candidates for this procedure. So what our robotic CABG is that's being performed here is a single vessel bypass of the lima, or sometimes known as the lita artery, to the LAD with a mid-cab incision. So if you can see on the slide here, our traditional approach is through a sternotomy, where we cut through the middle of the breastbone. That's seen on the far right bottom of the screen. And that gives us full access to the heart to perform as many bypasses as needed or work on valves. But for patients who have a blockage in their LAD, or their left anterior descending artery, they may be a candidate for this less invasive incision known as a mid-cab incision, which is on the left chest and usually under the left nipple, usually in that area. Through this incision, that's how we can perform that single vessel bypass on the heart and also harvest the left internal mammary artery, which is an artery that runs right on the inside of the rib cage, just beside the breastbone. And that is what we use to revascularize or bring blood supply to the left anterior descending artery. This, as you may be able to tell, is not me, but this is Dr. Gillenoff working at the robot, and this is kind of what the setup looks like in the operating room. We have the robot here at the patient, and in the patient, and Dr. Gillenoff is sitting here at the console controlling the arms of the robot to do what he needs it to do minimally invasively. When I don't have access to the robot, or previously where I trained and worked when I didn't have a robot, I would harvest the mammary and perform the bypass through this incision right here. So I'm working through this teeny little opening to harvest the mammary artery all up along the length of the breastbone, and I detach it from the rib cage and come all the way to the top of the breastbone and bring it down onto the heart. And so this is rather challenging because I'm looking through such a small opening and working in a very confined space. So the robot makes things much easier for me because it gives me great visualization, and I have 360-degree rotation of the arms to be able to grab the artery and detach branches and bring it down onto the heart. So why is this procedure done? Well, it really allows us to provide the gold standard of revascularization of that lima artery, which is our most durable, longest lasting conduit that we have to use for bypass, to the LAD, which is the largest territory of muscle in the heart, gets its blood supply from the LAD. So it's really the most important artery in the heart. And this is our best, longest lasting conduit. So with this small incision, we can do that. It is less invasive and allows for a faster recovery compared to a sternotomy. So the Achilles heel, I often say, or the hard part with surgery, is the recovery. Not the surgery, that's easy because I do that and the patient's asleep. But the hard part's the recovery because of that breastbone needing time to heal back together. And most patients are understandably not looking forward to having a sternotomy or that chest incision. But when we make this incision between the ribs, we don't break any ribs, so you're allowed to go back to your usual activities as soon as you're feeling up to it. And you can be driving as soon as you're feeling up to it, playing golf, traveling, hunting, any of those things you can do much more quickly with this incision compared to a sternotomy. There's also a decreased risk of infection for patients who might be high risk for infection. Again, because we go between the ribs, there's excellent blood supply to that area. And what we need to heal a cut after a surgery or after you cut yourself is blood supply. So with excellent blood supply, there's less risk of infection between the ribs compared to through the breastbone, where there is some decreased blood supply, especially when we take away some of that blood supply by using that mammary artery that runs beside the breastbone, when we take that off the rib cage to bring it onto the heart. And so the last reason why this procedure can be done, or one of the benefits of this procedure, is cosmesis. So with our scar, or with the incision through the middle of the breastbone, it does leave a scar there, and sometimes it can be visible, you know, if you have a low cut shirt or a V-neck shirt, whereas this incision underneath the left areola or the left nipple is hidden from view. It's hidden under clothes or hidden under a bra for women. So that is another benefit of this approach. So that's our traditional sternotomy incision. This is very typical, but very typical that you have this cut along your chest and a couple cuts below it that you can see with some stitches here. And so this is our traditional approach. Obviously, a bigger scar, and if this person has a lower cut shirt, you can see a bit of that scar there afterwards, compared to our incision that's done here, again, under the left areola, and post-operatively, again, a bit hard to see here, but the cut is right here. And we have one other cut that we use here for our chest tube at the end of surgery, as well as two other small cuts on the chest for the other arms of the robot to be placed inside the chest. So now I have a quick video that's showing part of this procedure, specifically where we open the pericardium, the lining around the heart, to find the target that we're going to bypass onto, and then actually harvest the artery off of the rib cage. So this does show us some of what we actually do in the operating room. This is sped up a little bit. Not moving this quickly always in the operating room with the robot, but here this is fat that we're freeing up off of the lining, the sac around the heart, and we enter into this space with these two arms of the robot working here that I'm controlling at a console. And by opening this lining of the heart, I then will be able to visualize and search for the left anterior descending artery, the artery that we're planning to bypass. And if you can see a bit of this white here, if you take my word for it, that's actually the artery right there, right in view. Now then I turn my attention to the chest wall, where I need to again free off this fat, which we all have this fat on the inside of our chest wall, to then find the left internal mammary artery, which is again this whitish structure here that's lying under this plane, this tissue, this fascia that I have to open to then get access to that artery. So with this camera of the robot, you can see I can look directly at the artery. I can zoom in, I can move left to right, so I am looking directly head on at what I see, and there's great light, whereas opposed to that still shot of the back of me you saw working through that little opening, I don't have this same visualization. I'm looking at things from an angle. The artery, when it's high up in the chest, is far away from me, can be hard to see. This allows for great visualization. But you can see it's a process of opening up through all the layers to finally get to the artery and to safely take these layers off without causing any damage to this artery. The whole benefit of this surgery is to provide that durability of that left internal mammary artery to the LAD. So it's absolutely vital that I don't damage that artery to the point that it can't be used or not provide a good bypass, because then you don't have that benefit of that bypass. And you can see there's all these little branches that come off the artery, which are quite normal, that I slowly have to disconnect, burn, clip, and detach. And so there's some example here of burning the branches, and then we'll get to a point in the video where we can see that I apply actually some clips on the branches of the artery. And so with the robot, we have all the same instruments that we would have in our regular open sternotomy case. These are just made specifically to go in the robot, and so we're able to detach branches with all the same instruments. And so this video, I'm going to skip ahead a little bit because it's the same detaching branches throughout. But what I really want to show is, as I get towards the end of the video, that with it I'm able to free up this artery, so I'm detaching it completely here from the rib cage. And we can go as high as we need to go, as we would in an open case, all the way up to the top of the artery with the robot. And if you take my word for it again, you'll appreciate it here, that right up here at the end of this incision is the beginning of that artery. And then we are able to go all the way to the end of the length of the artery and detach it from the rib cage with these clips, so then I can bring this artery onto the heart and perform the bypass through that small incision, that credit card size incision that's under the left nipple. And I detach the artery here. And then once that part is done, the role of the robot is complete and we're able to take the robot away from the chest, so I can then perform the bypass by hand. So who are we offering this procedure in? Well, right now it's in patients who have that blockage only in that particular artery, that left anterior descending, or patients who may be a candidate for having a bypass to that artery and potentially having stents put in other blockages in other arteries. And so this is really where this heart team approach is so vital and so important, because I'm in communication regularly with interventional cardiologists here to talk back and forth about patients that may be candidates for this hybrid revascularization procedure, where I do this minimally invasive bypass and the cardiologist potentially stents other blockages. So that'd be one big strength of our program here, but an important factor that we're looking at when finding candidates or deciding if someone is a candidate for this procedure. A patient needs to be able to have strong enough lungs that they can breathe just on one lung during the procedure. As you could see in the video, I could see the heart and I could see the chest wall, and that's because I was able to deflate that left lung during that time. And so someone has to have strong enough lungs, which is something we would identify on pre-op testing here at the clinic to know if I can offer you this procedure, if we can offer you this procedure. There's certain blockages I'm ensuring that a patient does not have to make sure that I can use the mammary artery and that it will be of good quality and provide good blood flow to the LAD. So that's looking at subclavian artery and looking for subclavian stenosis. And also a patient should not have had any previous heart surgery or left-sided chest trauma. Heart surgery or chest trauma results in a significant amount of scar tissue that distorts the planes, has a lot of structures, then causes a lot of structures to stick together and distorts the anatomy, and may not be able to safely enter through that scar tissue minimally invasively. What are some contraindications or signs that tell me I don't think I can offer this procedure to patients? Well, if someone is having active chest pain or they're unstable, if you're in hospital and you're having signs of stress on the heart or lots of chest pain, the safest approach is our traditional sternotomy approach. With the minimally invasive approach, you can imagine it takes a little bit longer or sometimes a lot longer than an open approach. And so I don't want someone unstable or having chest pain while I'm trying to do this longer procedure minimally invasively. If you've had that previous heart surgery or left chest surgery, again, because of the scar tissue, I may not be able to safely enter the chest with the robot minimally invasively, so you may not be a candidate. If I'm unable to access the coronary artery, then I can't offer the bypass minimally invasively. And so sometimes there's arteries that are hidden under muscle or maybe very, very small, or I have to go very high on the artery to do the bypass that I can't access from under that left nipple. And sometimes too, body habitus can make it challenging for the robot to be able to get in there and my robot arms to work together. Depending on body habitus. So that is something that I would be able to evaluate when I meet with you and also with some of our preoperative testing. So ultimately, the benefits of the robotic-assisted bypass or mid-cab is a faster recovery. There's no restrictions on activity, so you can get up and do your activities, driving, golfing, any hobbies that you like to do, you can do much faster as soon as you're feeling up to it. Really, patient selection is key. So this is something that I often need to decide by meeting with the patient and doing some tests to make sure that they are a candidate. And ultimately too, yes, this is a fantastic operation, but we can never compromise on the bypass quality just for a smaller incision or a less invasive incision, or on safety. And so though I like to offer this to all patients, they may not be candidates based on safety reasons or if there was any concern on bypass quality. but this is something that we are excited to offer here at Cleveland Clinic. As I said, it's one of my passions, one of my interests, and a surgery that I love doing. And the heart team together talk about these patients and decide together if we think we can offer this minimally invasive surgery and/or a hybrid operation to revascularize your vessels and give you the best, longest lasting and most durable outcome for you. So I thank you so much for your time. Thanks for joining me and for watching this video. We are always here. So if you would like to come to Cleveland Clinic for your bypass surgery, whether it be through a sternotomy or see if you're a candidate for a minimally invasive approach, I'd be more than happy to review your chart. There's a whole team of us that perform robotic operations, as well as the cardiologists that help review these cases with us. So as I like to say, we are always here and be honored and happy to be a part of your care. So thank you again.